Hello everyone, welcome back. This is KRS 420. This is going to be our second lecture covering chapter 2. We paused a little bit, kind of like halfway through chapter 1. We're going to come back to it, but this is a good spot to pause. We did about a 90-minute lecture introducing chapter 1. So this is a good spot to talk about chapter 2, which is the on-field assessment, or when we evaluate acute pathologies. Things are going to be a little bit different because, if there's an athletic event or it occurs kind of outside of the clinical setting, there's different time constraints and things we worry about and focus on that are very different than when we're sitting in our clinical settings. Okay. So with any evaluation that's acute in nature, immediate care, right? The number one priority is anything that's threatening your patient's life. If you've already had first aid CPR training, these are our primary concerns. And anytime we have someone injured, we must first rule out, R/O is rule out lack of ABCs, right? Airway, breathing, circulation. So is the heart pumping? Is there adequate pulse in the distal extremities? And are they breathing? Life-threatening head, neck, or spine injury. So usually there's going to be an acute event that happens where they're landing from a fall, there's a collision, there's a car accident, whatever the case might be, but high velocity injuries to the spinal cord. Of course, profuse bleeding, fractures, and dislocations. They can cause nerve paralysis if the nerve becomes severed, and then lead to bleeding, peripheral nerve injuries. Now getting into soft tissue trauma, those aren't really life-threatening, but they could have the potential. There's some that are life-threatening, right? So we would call all of these, your primary survey, right? Especially the ABCs. Okay, so because people take classes in different order, I'm not sure how many have had KRS 419, which is administration in sports medicine. But emergency planning, whenever you're working at a clinical site or you have a job in healthcare, the single most important thing you need is that emergency action plan. So before you show up to work your first day, you need to know when something goes wrong, whether that's a fire or a patient goes into cardiac arrest, or there's an active shooter situation. Regardless of what the emergency is, what are you going to do, right? Because everything should be thought about ahead of time. You shouldn't have to stop and think like, oh, well, something's going wrong. What do I do now? So the emergency action plan, and you can go to box 2-1, chapter 2 in the textbook. So every person or a job title, because people kind of filter in and out of position. So if it's by position, everyone should know what their role is, right? And everyone's contact information should be listed. There's been cases where maybe there's a weekend event at a football game, football stadium or field. There's a catastrophic heart attack from a parent or a coach. And they go down on the field and no one has the gate keys to unlock the gate so that the EMS can drive into the area. Right? People have died because EMS couldn't get to them. There's a famous case in Italian top flight football, like soccer. There was a police car blocking the ambulance's path, and a player died and had a heart attack on the pitch. All the equipment should be outlined, right? So if it's an emergency, where is it stored? Where is it located? Communication, that's obvious. Whether you're using cell phones or radios, who do you contact? All those things are very important. There was a case where a junior college in LA had a high school player during like a summer practice, a basketball team, which was kind of against the rules. The high school athlete dropped and had a heart attack, which is, very rare in young people. And they called campus security to bring the AED, right, the defibrillator, and they didn't bring it, right? So there was some communication breakdown, and that athlete ended up dying, right? It's very tragic when you think like maybe 5 or 10 minutes delay could be the difference between if someone lives or dies or not. And then standard procedures, right? So what are the transportation guidelines? Who's meeting the EMS or the ambulance and directing them? Who's taking care of the person who's down or injured? Right? All of that needs to be thought of ahead of time. Depending on the sport, they all have very different rules, especially if you wrestled before. You know, like there's an injury evaluation time limit. So you might only have 60, 90, 120 seconds. You might have a minute or two to evaluate them. You know, the trouble with that is, let's say a wrestler gets dropped on his head, he has a concussion. Sometimes they prevent very lucidly or clearly, and they don't have any symptoms. And then you check them, and they seem fine. And then 5 minutes after the match, they're complaining of exacerbation of their symptoms, and they're starting to have amnesia. That happens a lot. Right? So every sport has very different rules. Like if you ever watched a basketball game, if someone's driving to the hoop and they get fouled and they go down hard, no one runs out immediately to help them because they're seeing if they can get up and shoot the free throws. So if you come onto the basketball court, you have to come off for that play, which ends up being their free throw. Versus like soccer, you have to be called on by the officials because the play has to stop. So every sport has like very different rules. Okay, so I hope you guys can see this. It's a little obstructed from my toolbars in Zoom, but the last 5 years, the National Athletic Trainers Association, and in conjunction with physicians, and sometimes there's PTs or other specialists around, but basically for athletic events, before the competition starts, there's a medical timeout, which means athletic trainers, emergency medical services, like the EMTs, the ambulance, if they're there for football games, the team doctor, and then if there's any students who are assisting, everyone goes over their contact information. What's the hospital we send people to? What's the recommendation for removing equipment like football helmet or shoulder pads? Because if they get to the ER, then most of the time ER physicians and nurses don't know how to remove that equipment, which makes their care impeded once they get to the ER. So then you can see, depending on the level of injury, there's different protocols that should be discussed before the event starts, right? So there's no confusion when something goes wrong. Okay, this is a really great table. It tells you whenever you're evaluating someone throughout the different parts of the HOPES or the HOPS systematic evaluation, stop what you're doing, call 911, or get them to the hospital immediately, right? So when to terminate your evaluation. So during the history, if you're just asking them questions, inability to move limbs, right? If there's a head, neck, or spine, possible trauma or a fracture, they might not be able to move the limb. Significant chest pain, right? Of course, we're worried about heart attacks, strokes. I remember I was covering a football game for a junior college, and the defensive line coach, he fell to the ground. He was holding his head. He started screaming, "I can't see, I can't see." The head athletic trainer at the time, he signaled to me, and I had to run to the EMS that was parked in the end zone. So I sprinted to the EMTs and the ambulance. The guy was actually headed to go use the restroom, and I was like, "We need you right now." The coach was actually having a heart attack, but he lost vision, right? So there's always a variety of symptoms, but when things appear very wrong, when in doubt, just call 911. Of course, difficulty breathing, so anaphylaxis, either from maybe like asthma, or if they're having an allergic reaction to something. If you're not familiar with a pneumothorax, remember the pleural linings of the lungs are pressurized. You're able to breathe because when you take a deep breath in, the thorax expands, so the volume increases. That lowers the pressure below the ambient air. So remember, pressure always goes from high to low. So when the air pressure is greater than the pressure in your lungs, you're able to breathe. A pneumothorax is when you have a punctured lung. So maybe the ribs are fractured, it punctures the pleural lining, and the pressure, right? Pneumo refers to pressure. The pressure in your lung cavity normalizes with the ambient air because of the fractured rib pokes that lining. So if the pressure is the same, then you can breathe in and out, right? So this is a collapsed lung, a pneumothorax. During the inspection and observation, so any obvious fracture or dislocation, if they're knocked unconscious, the minor concern is concussion. People who are knocked unconscious and they only have concussion, traumatic brain injuries tend to fare very well compared to people who have loss of consciousness from epi and subdural hematomas, right? That's intracranial bleeding, or bleeding on the brain because it displaces the brain down onto the cranial nerves, and that's what makes people lose consciousness. Cyan is the color blue, right? Cyan is a bluish tinted color. So cyanosis is purplish discoloration of the face or lips from lack of oxygen. And of course, unequal chest expansion, we're worried about that, pneumothorax or a collapsed lung. So during the palpation, when you feel the joint or the areas that are injured, obviously disruption in the contour of the bone, we're worried about a fracture or dislocation. And then down here, joint and muscle testing and function. If they can't develop tension or torque in the muscles, one of the primary concerns is going to be fracture and dislocation again. Anytime they have gross or very lax or an unstable joint, so if they're not able to walk or put weight on it. During the neurological, right, so sensory, remember that's dermatomes. Motor is the myotomes. And then the spinal reflexes, which we'll have a lab and a discussion about for the upcoming assignments. Lack of balance, ataxia, right? So lack of balance and coordination is ataxia. And other symptoms of traumatic brain injury. And then vascular system, so obviously the capillaries, so it's going to be capillary refill, and then checking the distal pulses. Ideally, in an acute setting, you're going to have at least 2 responders, right? Someone to care for the athlete, someone to go and meet the ambulance or call 911, so you don't have to do both things at once. And then they can come back and help you to do like 2-person CPR. If you've never done CPR, like cardiopulmonary resuscitation, which is the chest compressions and giving breaths, it's very tiresome. You know, it takes a lot of effort and energy. So if you're doing it by yourself, then you run the risk of becoming gassed. Crowd control. So typically I would use an official, school administrator, or someone who can do crowd control, because you're going to be hyper-focused treating the person who's down, and you're not going to see, you know, all the people who could be milling about, you know, recording on their cell phone, coming to say like, oh, I know what to do. Like I took a class in college. So crowd control, very important. And then it depends on the injury, right? All injuries are going to be a little bit different. Okay, gonna pause and take a little sip of my coffee. Oh man, that's good. Chocolatey, rich, delicious. Okay. So that's our primary survey, right? Things that are life-threatening. And then the order that you rule them out. So cardiovascular system, so heart attack, stroke, breathing, respiratory, that's the most important thing, right? Are they breathing, and is the heart pumping? Head, neck, and spine, trauma, profuse bleeding, right? So this is kind of really, really create a cutoff point here of like these things, you know, you got 10, 15, 20 minutes, depending on the severity of where there's irreversible damage. And then from fractures, dislocations, and other types of trauma, very serious, but not always life-threatening. So in the acute settings, usually most of the equipment is left on, or clothing is left on. Heat illness is a very good exception, because if someone's having a heat stroke and they're overheating, and the cooling mechanism in the body is being disrupted, they can't cool down, that is a very life-threatening condition. So the only reason, you can see in this picture here, they're draping towels so that they can use a rectal thermometer, because that is the most and only accurate measurement of core temperature we have in the field setting. Temporal scanners, axilla, under the tongue, those thermometers are usually off by a few degrees. And with heat illness, you always cool the patient first and then transport them second. So typically if someone's at internal temperature of 102, 103, or even up to like 105, 106, 107, those are really scary situations where you have to cool them in ice water if you have it, or temperate water. Room temperature water is next best. Fans, ice packs, those don't work. It takes 30 minutes, up to the neck in ice water or temperate water. Those are the best options. And then the rectal thermometer, you only transport once they're below 100 degrees. Because if you start to cool them and it's only like 5 minutes in an ice bath and then EMS takes them away, their temperature will continue to go up because the cooling mechanism is disrupted. People have had serious organ failure and death because they were removed and transported to EMS too quickly. Okay. And then general equipment stuff, obviously if it's a heart attack, you have to open up to put the pads on for the AED. So in that case, clothing's removed. And then for football equipment, helmet and shoulder pads should be removed, before we transport them for anything head, neck, spine, or thoracic injuries. Okay, so this is a nice little flow chart you can read through of the primary survey. So the main thing is, if you think there's an injury, we're going to stabilize, determine consciousness. If they're unconscious, calling 911 immediately, and then thinking about airway, breathing, and circulation, right? And if they're choking or not. And then if they are conscious, obviously they're breathing and they have a pulse. So then you work into, is it head, neck, and spine trauma? If it's not head, neck, and spine, then you start moving into your evaluative tests. That takes us to the secondary survey, right? So things that are not life-threatening, they're serious, right? Primary survey is life-threatening. Secondary is serious things that aren't life-threatening. So it could be minor bleeding, gross deformity, and other things. So there's a little bit of overlap between things that could be life-threatening and those that aren't. Big thing, keeping people calm because they're typically injured, they're in a lot of pain, and they might freak out if they're looking down and they see like a gross deformity, like open fractures and dislocations. I've had several of each in my athletic training career, and most of the time people were calm, but I've also seen like a pole vaulter. She was going up and started drifting to the side and she missed the mat. She had an open fracture dislocation of her ankle. And she was kind of freaking out. So you have to cover with a towel, try to immobilize it. And then someone's there trying to talk to them saying like, it's going to be okay. We got you. We're going to get you to the hospital as quickly, as safely as we can. Okay. So if you're working just on the secondary survey, so minor injuries, the big thing is, do I need to call 911 or not? Right. So for fractures and dislocations, that's obvious. But for things where you're unsure, young clinicians often have trouble like, does this need me to call 911 or does it not? And that just comes with experience. Okay. So the on-field history, obviously it's going to be a lot quicker. You're just working through, the ABCs initially, pops, snaps, sounds, things that might clue you into like fractures or dislocations. And then trying to quickly move into the palpation. The observation is pretty straightforward, right? Is it an open fracture, dislocation, or something obvious? Are they unconscious? Those things are pretty quickly that you're working towards. Are they having normal ABCs? And if they're not, then severe injuries. So one of the more important parts, of course, determining if there's a fracture is during the palpation. So if you don't see anything obvious, right, we really want to make sure our palpation focuses on the bony structures, right? So is there deformity? Are the joints aligned? And then trying to rule out fracture or rule in fracture via palpation. I've had a ton of fractures I've seen. I'll never forget one. A guy was running towards the goal line. Someone jumped on his back in football. So he had downward weight, and someone cut him right at his lower leg. So they dove and tried to tackle him while he had someone on his back. So I got over to him. He was in a lot of pain. I tried to just passively straighten his leg. There was a little clunk in his shift. And then when I was able to palpate it, it felt like he had two joint lines. So the normal one where the femur meets the tibia, and then there was a second line going all the way across his tibia. So I went over to his good knee. I was like, he definitely has one joint line. Went back to the injured one, and he'd had a complete tibial transverse fracture all the way across. So that's a scary one, right? Because you worry about nerves and arteries being severed as well. And then after you kind of think about what the bones are like and the joints, then you move on to the soft tissues, so ligaments, tendons, and then muscle fibers. And then, so if you think at that point they have a fracture or dislocation from the palpation, you're obviously going to stop and call 911. If you don't think they have a severe injury, then you can ask them to move it, right? If the palpation tells you, like, I don't think it's fractured, so I'm thinking maybe it's like a ligament or muscle injury, a sprain or a strain, you can ask them to move it, active range of motion. If they're not willing to move it at all, right? They're not willing to complete active range of motion, stop what you're doing, think about how you're going to transport them, get them to the ER for either x-rays or an ortho workup. Right, so this is kind of a stepwise progression. You always start with active. And then, of course, if there's some nerve issue, then they won't be able to move it as well. So it's either going to be from the spinal cord or from a peripheral motor nerve. And then passive range of motion, we're predominantly checking the infield, so the ligaments and the capsules. So if they can do active and passive, then you can move on to strength, because this is the most stress, right? The most torque or force applied to tissues, which could cause pain and discomfort. So if their strength is fairly normal, then you can have them try to stand up, right? Weight bearing. So this is a stepwise progression that you do. First active and passive, then you do a break test, and if they can pass all those, then you can see if they can stand up if it's a lower extremity injury. Okay, and if they can't complete any of these, you're going to have a way of transporting them. Either EMS is coming directly to them, or you're going to have to transfer them off that surface or area, and then getting them to either the ambulance or directly to the hospital. Yeah, so if you're thinking it's a ligament or the joint capsule, we do stability tests. That helps us determine if we think they can walk or not. And then neuro. So the big reason we do a complete neurological exam anytime there's a head injury, one is the cranial nerves. So I want you guys to think to yourself, do you remember all 12? And then what do they do? So if they're altered, what does that mean? You know, if you have altered cranial nerve, some are motor, so you get movement of the faces, the tongue, and the eyes. Some are sensory, so that's like vision, hearing, balance. And then some are mixed, right? So you get a little bit of both sensory and motor. So we're going to see this on the next slide. Then we have the spinal nerves, right? So the ones that have left the spinal cord and now they're in the periphery. So abnormal skin sensation, that's the dermatomes. Inability to move or improper movement patterns, right? So spasms, that's in the myotomes, and then the reflexes. And then you always want to assess motor function distal to the injury, right? So if they have like a head, neck, or spine, you ask them to wiggle their toes or wiggle their fingers. Okay, so here are the 12 cranial nerves. So remember, some are smelling, some are vision, those are the special senses, and taste, and others are motor, so movement of the eye, and then pupillary reflex, right? Those are all motor responses. Cranial nerve number 8 over here, balance, vestibulocochlear, right? So balance and hearing. So if we think about where they're at anatomically, we already briefly talked about epidural and subdural hematomas. That's intra cranial bleeding, right? So inside the skull, if there's bleeding on the brain, it pushes the brain down, right? Because the cavity starts to fill with blood that's escaping from the vascular system. These cranial nerves are on the underside, right? This is the spinal cord coming up to like the pons, the medulla, and then this is the underside of the cerebrum, right? So we're kind of at this level in the frontal lobe at the base of the skull, right? It's the underneath side. So you can imagine when the cranium fills with blood, the brain gets depressed down, and these cranial nerves become compressed. And then that's when people have deterioration of these cranial nerve functions, right? So anytime people are having altered vision, blurry vision, changing their levels of consciousness, inability to speak and move the tongue, problems with balance or hearing, that's an immediate red flag. They need to get to the hospital immediately if they've had a head trauma, because they could have bleeding on their brain. A little bit different than concussion. Like most concussions are, I wouldn't say minor injuries, but compared to like bleeding on the brain, they're minor. Okay, and then there's the vascular assessment, right? So the two most distal pulses we have in the foot, we have the posterior tibial, right? So right behind this is the medial malleolus. So we'll learn this in chapter 8 and 9. And then the dorsalis pedis is on the top of the foot, right by extensor hallucis longus, right? So my red cursor is kind of where extensor hallucis longus tendon is at. So that dorsalis pedis is just lateral to that tendon. So those are the two distal pulses. Capillary refill. So in the toes, like say you grab the nail bed, you squeeze it, all the blood gets pushed out, and when you release it, that blood should refill in about a second. That's how you know that there's perfusion all the way to the distal end. Okay, just a couple slides on splinting. So if there's an acute emergency situation, if you're not an athletic trainer who have specialized splints and spine boards or EMTs, the cheapest thing you have laying around your house is a good old pillow, right? It's very moldable, not too fluffy. If you get your flattest, most thin pillow and a little bit of duct tape, you can see this ankle has been immobilized. So anything fracture or dislocation, we're going to mobilize so that we can transport them effectively. So just a couple principles. I don't expect you guys to be experts in this, but it's just, you know, some general things that are important to know. We often leave it in the position that we find it. We don't want to increase the amount of injury. So if it's a fracture or dislocation, we just immobilize it and then get them to the ER. We always stabilize above and below, right? So proximal and distal. So if it was the knee, you might do like a straight leg immobilizer where they can't move the knee at all. Like if it's the ankle, you might have to mobilize the knee, and vice versa, right? Okay, and then 3, 4, 5, and 6 are all about what happens afterwards. So you've splinted them, depending on how long the drive is to the hospital. Sometimes it's 5 minutes, sometimes it's 45 minutes, depending on where you live. Sometimes it's longer than that, right? If you're trying to get to from a neighbor island, let's say there's a traumatic injury that you need surgery on immediately, from let's say, you know, Hilo, and you're trying to get to Queens because that's the level 1 trauma center in the state, that's going to be a long transport, right? So you might have to drive to the airport in Hilo, you might have to get transported on a helicopter and then transferred to Queens into like the operating room. Sometimes that takes a long time. So if there's a significant trauma like a fracture or dislocation, there's going to be swelling. There could be changes in their sensation levels and skin temperature, and then blood flow, right? So if you secure it too tightly, you're going to compress the area and you could cause more injury. You want to give it enough room to swell up and then still continuing to check capillary refill and their dermatomes and myotomes regularly to see if there's any changes. Okay, so when you determine that you need to extract or get them out of the field because they can't walk themselves, the easiest one is assisted walking. So if there's 2 people, injured athlete drapes their arms over the shoulders, or you could do like a 2-person seat carry. If you have some extra time and you're a soccer fan, or if you're not a soccer fan, but if you've ever seen stretcher fails on YouTube, those are great videos to watch because you can see people a variety of skills in getting people off soccer fields using the stretchers. Because, soccer players are usually faking it. It's only like 90% of the time. I can say that because I used to play a lot of soccer. And then full spine boarding, obviously, if there's a head, neck, or spine trauma, you're securing them to the board using straps. There's no straps in this diagram or picture, but now we remove shoulder pads and helmet before we transport, and we practice that regularly every year in the off season and leading up to football season. It's one of the skills we really drill in sports medicine, is being able to prepare for head, neck, and spine injuries. Yeah, so your major disposition is figuring out quickly what's wrong with the person. Do we need to refer them to EMS or a physician immediately, or maybe even a dentist if it's a tooth injury? Or do we just provide, immediate care? And then what's the return to play or RTP decision if it's like a day of injury? Right? So if you evaluate them and you think they can continue, there needs to be like clear, objective goals for everybody. Yeah, so that's the big concern. If you let them back in the same day, what's the risk of re-injury or furthering the injury to a catastrophic level? Right, so with younger athletes, you're always going to be more conservative. If they're professionals or they're, weekend warriors, then, they can do what they want because they're adults. Okay, so that wraps up chapter 2. So at this point, quiz 1 should be open, or it will open shortly. Quiz 1 is going to focus on the 2 posted lecture videos. Right, so that was chapter 1. That one was about a 90-minute. This one was a lot shorter. So you get about 2 hours of recorded lectures. Make sure you're reading the chapters and going over the PDF notes, and then check your email, and it will let you know that quiz 1 is open. Check La Lima for any due dates. It's just covering chapter 1 and 2, the video lectures that are posted. You're going to get a random draw of 10 questions from a large pool. So everyone's quizzes are going to be a little bit different. All the questions have a similar difficulty. And you always get 1 minute per question. You'll be able to see feedback after it closes for everybody. So not when you're done, but when it's closed for everybody. And that's going to be the due date posted in La Lima. So always check your emails and make sure you're following La Lima for updates. Everything should be posted. I wish you guys the best of luck. See you next time.